Mantle cell lymphoma is clearly a pretty heterogeneous disease, maybe more so than was recognized even 10 years ago. So biologically speaking, I think it's now widely recognized and is in the World Health Organization classification of lymphoid neoplasms that mantle cell lymphoma has a leukemic non-nodal presentation. Those mantle cell lymphoma cells tend to evolve from a cell that passages through the germinal center reaction. They tend to be SOX11 negative, they tend to be IGHV mutated, and they tend to have a more indolent clinical behavior. Some of those patients may go on to develop TP53 mutations and blastoid transformation. Separately from that, there are the more classical mantle cell lymphomas, the typical nodal patients. These are derived from mantle cell lymphoma cells that have not passaged through the germinal center. They are SOX11 positive for the most part and IGHV unmutated for the most part. On average, they tend to have a worse prognosis than the leukemic non-nodal patients, although probably about 20% of them or more can be observed for some significant period of time. Simon Roll presented data suggesting that many of them could do well for a couple of years without any therapy. So biologically, there are differences there. Additionally, as I mentioned, the blastoid morphology, which comes with a more proliferative state, tends to do a little bit worse. And those patients with TP53 mutations or high P53 protein expression tend to do worse. Oftentimes, Ki67, blastoid morphology, and P53 go hand in hand, but that's not universally true. And probably those patients should be managed differently. Specifically, the patients with P53 mutations who are not blastoid could be managed with non-chemotherapy approaches. Those patients with blastoid morphology and P53 mutations should be offered probably allogeneic stem cell transplant early on in therapy or be considered for clinical trials with CAR T cells.